Hello, everyone, and welcome to today's event. We are so glad that you could join us today for the International Day Against Homophobia, Biphobia, and Transphobia, IDAHOBIT, panel discussion, healthcare inequities, barriers to care facing LBQT communities. My name is Alan Kuriakous, and I'm the fundraising coordinator at the Stephen Lewis Foundation. Before we begin our panel discussion with our wonderful speakers today, I just have a few things to cover. First of all, we welcome you to use the chat today to introduce yourselves and to engage in the conversation. We recommend that you select everyone from the drop-down menu so that everyone in attendance can see your conversations. Since today's event is only 1 hour, we encourage you to submit questions through the Q&A feature or the chat during the event, and we will do our best to incorporate them at the end of the discussion. Now, as we get started, I would like to start with our land acknowledgement. As an organization based in Canada, the Stephen Lewis Foundation acknowledges that our presence here is a direct outcome of the settler colonial state whose policies of expulsion from the land and cultural genocide continue to impact Indigenous communities today. I'm joining the event today from the offices of the Stephen Lewis Foundation, which are located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples, and is now home to many diverse First Nations, Inuit, Métis, and Métis peoples. The Stephen Lewis Foundation acknowledges that oppressive and inequitable socio-economic and political systems in Canada continue to perpetuate a legacy of racism, intergenerational trauma, and structural inequality, and that this legacy is directly linked to the disproportionate impact of HIV on Indigenous communities within Canada. We at the Stephen Lewis Foundation are committed to the principles of social justice, equality, and solidarity with our community-led partners as they face the continued effects of colonialism, including the homophobia and transphobia we will be discussing in today's event. Consistent with those values, the SLF is undertaking a journey of ongoing learning, reflection, relationship building, and solidarity with Indigenous communities in Canada. Today's event, Healthcare Inequities, Barriers to Care Facing LBQT Communities, is an attempt to explore the reality of healthcare access for the queer community and the inequities that continue to persist after much progress that has been made. Every year on May 17th, we recognize International Day Against Homophobia, Biphobia, and Transphobia, IDAHOBIT, and call attention to the health and rights issues facing LGBTIQ individuals around the world. At the same time, on IDAHOBIT, we celebrate and amplify the activism, accomplishments, and strength of LGBTIQ communities. This year, for our annual IDAHOBIT Pride Talk, the SLF will be highlighting 3 brilliant African LBQ leaders and their organizations who are working to ensure that HIV and other health services meet the needs of LBQ and trans communities. Around the world, LGBTIQ people are regularly failed by heteronormative health services and discriminated against by homophobic and transphobic healthcare providers. Now, an increased focus on key populations programming is growing. HIV services for some members of the LGBTIQ communities, but other queer and trans people are still being left behind. LBQ women and trans people who do not fall within the key populations are considered to be epidemiologically insignificant, and as a result, they aren't adequately targeted by many HIV programs. At the same time, most sexual and reproductive health and rights programs continue to be geared towards heterosexual cisgender women. As a result, LBQ women and many trans people do not have access to health programming related to HIV, cervical cancer, contraception, or prenatal care. Thank you for joining us this IDAHOBIT as we amplify the voices of our partners and allies who work with LBQT communities to bring this discrimination to light. Hear about the challenges they face, what their organizations are doing to bring change, and how you can demonstrate your solidarity. To begin the panel discussion, I introduce you our moderator for the day, Tamar Carter. Tamar Carter is an advocate, community leader, parent, business owner, educator, and manager of the Ballroom Empowerment Program at Maggie Strong. Tamar advocates for addressing systemic and social inequalities that disproportionately affect the most marginalized of sex workers, uplifts members of the ballroom scene, and is one of the leading forces behind Function, a platform for ballroom-first culture, stories, and events. Tamar founded the Canadian chapter of the Kiki House of Louboutin. Since joining the Toronto ballroom community, Tamar has become one of the most decorated members of the Canadian ballroom scene. I wish you all an empowering and thought-provoking discussion. Over to you, Tamar.
Thank you so much, Alan. Hopefully everyone can hear me okay. It's an honor and a pleasure to be with you guys today and to moderate the panel discussions. So I'm going to just introduce our very first panelist, Mary Audrey Shard. Mary Audrey Shard is a human rights defender from Zimbabwe, instrumental in the LBQ women's movement. She was secretary of the Gays and Lesbians of Zimbabwe in 2009, chairperson in 2010, and co-chair in 2014. Mary co-founded Rise Above Women's Organization, RAWO, and currently serves as director. RAWO advocates for the advancement of rights and freedoms for lesbian, bisexual, and queer women, including sex workers, and inclusive of women in all their diversity. RAWO works to counter stigma and discrimination, which has led to exclusion from full and comprehensive medical care, undermining of underlying mental health care, exposure to sexual and gender-based violence, including forced marriages, harmful cultural practices, and rape. So thank you, Mary, for joining us today. And we also have Hilda Mangai. Hilda Mangai is an LBQ leader in Kenya who has been working with Mandela Peer Empowerment Group, MPEG, for 4 years. Hilda connects LBQ community members through networks within Kiambu, I believe, County, to enable them to access sexual and reproductive health services, including STI screening and treatment, HIV testing, and prevention services. Hilda also works to ensure LBQ communities are accessing dental dams. Additionally, Hilda provides referrals for respectful interventions for mental health, gender-based violence, alcohol and drug use, and legal aid, and provides for LBQ events and, provides support for LBQ events and activities, including legal clinics and supportive supervision of LBQ peer educators. So thank you so much, Hilda, for joining us today. And last but most certainly not least, we have Fauzia Elaine. Fauzia is a bisexual sex worker in Kenya who serves as a community paralegal officer with the Bar Hostess Empowerment and Support Program. She advocates for the rights of young female queer sex workers. As a survivor of sexual and gender-based violence, she serves as a role model for survivors of violence in her community who do not have access to information or adequate understanding of how to navigate their experiences. She now serves as a liaison between LGBTIQ communities and legal justice systems through her role at BHESP. Through her work, she has created an oasis of safety for LBQ sex workers in Kenya she envisions a society where LBQ community members may easily navigate through the corridors of justice without any fear of stigma and discrimination. So thank you. Thank you all for being with us today. Can everyone hear me okay? We're all good? Yes, perfect, perfect. I was gonna wait for Mary. There we go. Okay, awesome. Okay, so I'm going to kick off the very first question, which is open to all. The very first question is, tell us a bit about the current landscape of what health services and access are like for queer people in your communities. And what about sexual reproductive health and rights and HIV programs? And the third part of that question is, do any programs prioritize the needs of queer individuals in your community? Let's start with Hilda. Sorry, Hilda, I think you're muted.
Sorry, I was muted. I'm sorry. Thank you so much, Tamar, for the opportunity. So to answer your question about the current landscape, we do have government provided services, but they usually cater to mostly gay or male presenting persons. Access for queer health in my community is actually very challenging due to significant, discrimination and, inadequate care. And despite, the constitutional guarantee of healthcare without discrimination, individuals who identify as queer often face homophobia, stigmatization, especially in public healthcare facilities. This leads to many people like me to avoid government hospital and seek alternative, sometimes harmful treatment method. One of the major issues I would say that has led to this discrimination is the criminalization of same-sex relationships under the Kenyan Penal Code, which of course fuels, society and institutional discrimination. Although on the bright side, sexual reproductive health for queer people is accessible and available in queer clinics like MPAG drop-in center, and there are HIV services freely offered in all GOK facilities as well as queer clinics. But of course, in these places, the LGBTQ are not prioritized. There are programs designed, like the one I'm heading in my community that are designed to reach out to queer people with comprehensive package of HIV interventions, through MPAG. Yeah.
Sorry, grateful for the work that you're doing. Super, super, super important. And just it just warms my heart to hear what happens around the world, because we do so much stuff here and also have issues with like the inequalities when it comes to different gender identities and sexual expressions. There's a lot more attention, I guess, and resources available for cis gay men or male presenting folks than there is for the rest. Lori, how about yourself? I think you're on mute as well. I can't really hear you.
Is that better? Okay, thank you, Tamar. Thank you for having me here. Okay. Zimbabwe, like most African countries, holds a hostile context towards the LGBTI community. And this is characterized by lots of intimidation, stigma, discrimination, and violence, and more so for LBQ women as the communities are further marginalized within the legal frameworks, within the cultural systems, the religion, and other social issues. So there are clinics that do cater to KPs, but what we have found out now and through our work, we see that KP in itself is very exclusionary. So the issue around the other vulnerable populations becomes really an issue for them in accessing healthcare. So Zimbabwe economy in itself is in a very, very bad state at the moment. So our healthcare systems are mainly provided by donor support. And with the donor support, they actually favor other communities over others. So as much as there is opportunities for gay men, to have access to healthcare. The other communities suffer outside of that. And in Zimbabwe, we as communities have pushed to ensure that we no longer use the term KP, but we use KVP because that is inclusive of everybody. So at country level, we have advocated and made sure that when there are issues around sensitization, issues around access to healthcare facilities, that it is inclusive of all the other communities that are unable to access services. Although the funding doesn't flow that way, even within the services that are provided, we still have at least some access. And I think that kind of work still has to continue. LBQ women are normally excluded from the broader discourse of women's issues and also the HIV discourse, because there seems to be a scientific view around HIV, and LBQ women are supposed to be epidemiologically insignificant to be included in any studies. And the women's discourse, they just don't have any data that actually speaks to us on issues around violence, issues around access, issues around the deniability of any other social issues. So this is work that we are actually working on right now. Zimbabwe still remains very hostile towards the community as a whole. And we find that year by year, the levels of violence continue to happen more and more often amongst the community, even within the healthcare facilities. So it is work that we have to continue with. And yeah.
Well, we're very lucky to have you on the ground. Absolutely. I know how passionate you are about this work. And it can't be easy, especially with the laws working against folks. So thank you for the work that you do. Fawzi, I'm not sure if you would like me to repeat the question. I just popped back in, but just asking me about the landscape of health services and access for queer people in your communities.
Hi everyone, and thank you for the question. My answer would be healthcare services have always been an issue for LGBTQ and sex workers in our country. Yeah? And sex workers for the longest time, like it has been an issue for the longest time. And this has hindered the LBQ community to access health services in both private and public health facilities. Sexual and reproductive health and rights and is a major problem. Stigma and discrimination has been hindering the LBQ community to access sexual and reproductive health rights and access to HIV prevention, treatment, and care services. Most public facilities are the motherboard of stigma in our country. Healthcare workers they question, they judge, and also calling upon their colleagues to see the LGBTQ other than giving them healthcare services. Sexual and reproductive health right is a heavy task. Most LBQ tend to use Google and over-the-counter services because of the fear of stigma given at public and private facilities. Drop-in centers have been the only options for the LBQ community, but they also have limitations because they don't have the capacity to facilitate all the healthcare services that the LBQ need. Thank you.
Thank you so much. I want to ask Mary a question. We know from the research that your organization has participated in, the LBQ women and trans women face a particular set of challenges regarding health programs and services. Can you tell us about that research and what you found?
Thank you, Tamar. The research was one of the biggest milestones that we have ever hit when we entered into partnership with an organization from Namibia called Positive Vibes. And they had a process called IMAKI, which stands for Integrated Monitoring, Accountability, and Quality Improvement, which speaks to the quality of services that recipients of care get from any healthcare facility. This for us was so important for us to engage in, because it then helped us to actually collect data. What we did is that within that Imaki process, it's a cyclical process, and one of the cycles they produces a tool called Mabox, and that tool has a questionnaire that everybody that accesses a health facility can speak to their experience. And why we wanted this work and this information was so that we can also gauge how many, if any, LBQ women are accessing these healthcare facilities and self-identifying. Because at times they do go to the clinics, but they do not identify themselves as queer women. This was an amazing process, and we did it in Harare for about 4 months, and then we expanded it with the assistance of another funder that came in, Arasa, through Love Alliance, and we expanded it to 3 other cities. And we collected data from countrywide. It was almost 9 facilities, and we collected data. And what that data showed us was that there are many LBQ women that do access these facilities, but at the same time, a lot of them are also experiencing stigma and discrimination. So they are not getting comprehensive health care. They are going to the facilities when they are already at an advanced stage of being ill, or they find that they are thinking that I really have no choice now, but then they do not complete their treatment. Something else that we found in this study was that LBQ women do want to seek other services outside of HIV, because a lot of the LBQ women are now engaging in sex work because of their economy. So they also need information and treatment around issues of sex work. Mental health issues. Nobody has been offering really comprehensive healthcare issues around mental health for LBQ women. So we have found that we have a very large community. And then coupled with this research, parallel to that, we also had a survey in which we then spoke to, it was 225 LBQ women, and we asked them to share some very personal and very private issues. And we found that many LBQ women are living with HIV. Most of them are married or they're in forced marriages. A lot of them are still experiencing rape, and the rape, for about 85% of them, that kind of sexual violence has started in the home. And for 3% of them, that sexual violence continues because they are still in the home. So that research has brought out a lot of issues for us. And I think for the first year that we have done this, we have managed to get some data. The LBQ data did not have a very large size estimate because, again, the women still weren't confident enough to present as lesbian women. But we do have a size estimate. And so now we want to try and use that within the country coordinating mechanisms that inform now our country level reporting around the issues of HIV. We were not able, however, to continue that research in the other 3 cities that we had started in. And right now we are only doing it in 1 city. In the past 2 months, we've only been able to support 1 city, because to do this data, we need to have a person that has a tablet that accesses these facilities and speaks to the people that access the facility. Those individuals also need to be supported as well as the tool itself. So right now we are only working from Harare, but we still hope that we will be able to continue doing it in the other 3 cities and to expand to 3 other cities. Because of our dialogues and our conversations, we've been able to gauge when we are giving feedback from this tool, you know, the need that is there, and the other cities now and the other members that are saying, please, can we have this? And one very important thing that came out is the country level interest in this tool and the way it works. And we have had country level institutions and committees that have approached us and said, we want to try and work with you with this tool and see how we can actually use it. But community-led monitoring is not being done very well in Zimbabwe. And one of the things that we are afraid of, if we enter these partnerships, we will very quickly lose the autonomy of the tool and again go back to our tool being used, but our people being excluded. And that tool right now caters for everybody. We do not have certain communities in it. It is everybody. If you are a Zimbabwean citizen and you access a healthcare facility, we want to hear from you. And so why we did it that way is so that we can be instrumental and intentional in our reporting and make sure that we are providing to the ministry or to the country level mechanism that this information is coming from RAO, and RAO, that is a lesbian and bisexual and queer women identifying organization. And we have collected this data and we'd like to share it with you, and also to give them our reports and the analysis. We have been very intentional in that.
That is so incredible. Sorry. And ideally, like, the data will feed into the government and will actually make change. Like, that's the hope, right? That the more data comes through, still protecting the people of Zimbabwe, but also like making change, forcing change, if that makes sense. Yeah, so thank you for that. Fazia and
sorry?
Yes, absolutely.
I wanted to say that why we also want to use our own reporting systems is because we want queer people to be captured as queer people. If my name is to appear, the column that I must appear under is not as a woman, but as a lesbian. It must be clear, you know, and in some of the other reporting systems, queer people are either all put, lesbians, bisexual women, trans identifying women, we are all just put under women. And that does not speak to our specific needs at all. So we were very intentional in also ensuring that our reporting is not talking only in numbers, but is also mentioning the communities specifically. Thank you.
Absolutely. I just wanted to piggyback off of that a little bit with Fazia and Hilda. Does what Mary with what Mary shared, does that resonate with your experiences at all with the BHESP and the MPEG? What are the consequences of these inequities for LBQ and trans women specifically? We can start with Fazia.
Oh, okay. The consequences are as follows. Yeah, trust issues, active participation, attitudes, and happiness affect LGBTQ and trans women individually. LBQ and trans women who live in less equal societies are less likely to trust each other or live alone trusting anyone. They are less likely to engage in any social or civic participation, and less likely to say they are happy, and that affects them mentally. And insecurities cuts across because they don't feel safe amongst anyone or in any place. Lack of enabling working environment for LBQ and trans women, being that we work with and for LBQ and trans women who are sex workers and they do sex work for a living. And they do sex work for a living with all the inequities around them, they cannot look for clients. And at some point, the clients are their number one perpetrators, yeah? And this leads to gender-based violence, and also their financial stability becomes a problem because they can't sustain themselves with basic needs. Also, there is this dusk dawn curfew in ASAL areas in the sub-Saharan side of Kenya that the dusk to dawn curfew has crippled movement for LBQ and trans women. Most of them operate during the night hours. So being that they are under curfew, they cannot be able to reach to their clients, or clients cannot come in for in call services. LBQ and trans women from the sub-Saharan Africa, and by default coming from maybe Islamic culture and religion, I, as one of them, we have been exposed to stigma and discrimination, surrounded with culture and religion, and extensively living in a country that has been criminalizing sex work and multiple sexual orientation. Based on this, we have been exposed to human rights violations, such as police harassment, societal stereotyping, and punitive laws. We also have been we have been targets of crime and being accused of carrying and transporting firearms when arrested, which is a lie, because like they cannot show evidently that they don't have evidence or proof that we are sex workers. Also, insecurities among the people working at the drop-in centers, because the general population, like the general communities, tends to say that they send backlash to the healthcare workers and the service providers at the drop-in centers, saying that they are recruiting their children and young boys and girls in the society to be lesbian, gay, bisexual, trans women, and sex workers at large. And also death is also a heavy consequence, because some of us get kidnapped, some of us get physically abused, some of us get sexually abused, either by the general population, the law enforcers, like even our community members at large, even our partners itself, like we get into violation with them and we cannot reach to anyone because we are quoted as a caste community, and we end up at some point even getting killed. It has been the talk of our headlines in Kenya for some time now, and sadly it's still happening and no one is talking about it. Thank you.
Thank you so much for sharing. Something that stuck with me when you first said it at the beginning of what you were saying just now was the trust issues. And it's LBQ and trans women literally just trust everyone. It's like a natural disposition in order to like preserve life, you know? So yeah, thank you for sharing. And Helga.
I think I would say, the repeated theme in most African countries is, stigma and, discrimination. About a year ago, the Supreme Court, allowed, LGBTQ people, freedom of association. And of course, we've faced discrimination before that. But after that, because of the, lack of education from the, general public, I think they understood it to mean they're, legalizing, queer people, and there has been a lot of violence against queer people, and one of the consequences of that is fear. We live in fear. Actually, my friends and I, we have this thing. We say we are, proud and out. But if someone asks, we say deny, because you don't know, what, their intention, is, once they find out, whether it's family. So you get to live in fear, what your family may, how your family may react, to your friends, the community at large. And something that resonates from what Mary shared is conversations with the government. It's very hard to come to a place where, you're fighting for your rights as, a queer person, as an LBQ person. You want, to be treated fairly or equally as everyone else who visits a hospital. You want, specific, health services that that are catered to you as an LBQ person, as a, trans woman. And, when the government itself has criminalized all of this, it's very hard to, have that conversation. And I would say something else that, we encounter at MPAG is you'll find people in the community still lack education on themselves, on how to deal with situations and things like that. And of course the government treats LBQ women, of course, I'm not saying gay or male presenting persons have it better, but they do to some extent, in the case that, as Mary said, there isn't a lot of data on LBQ women and, HIV. So there is a lack of education in general when it comes to things like that. Yeah.
Thank you so much. I just want to keep you there for 1 second. Hilda, can you also share some examples or stories of how these inequities continue to affect the lives of LBQ women and trans women? So experiences, stories, anything that you can share with us.
I would say some of the situations are, like I said, confidentiality concerns. Many queer people, again, like Mary said, they're very wary of disclosing their sexual orientation, or gender identity to healthcare providers due to concerns, about confidentiality. And, like Fozio mentioned, you'll go to a public hospital, and, if you're presenting the way they're used to, especially maybe feminine presenting men or trans women, and then it will be, I have witnessed this, it will be somewhat of a joke, like, oh, come see this person, come see. And then they're very inappropriate questions, especially when you present the way they don't expect you to. It's quite something. So people will, LBQ persons, trans women, will avoid seeking out, healthcare. And of course, there are things like, inadequate SRH, services. A lot of them do not cater, like I've mentioned before, they do not cater to LBQ and trans individuals, especially in, developing countries and countries that, like Kenya, where it is criminalized. And, things like, economic and social barriers will prevent you from going to a private hospital, which is, even when you can go to a private hospital, the care is not guaranteed, because a lot of people are not sensitized on how to handle or treat LBQ persons. And a major thing that queer persons face is violence and harassment, especially for those who present, masculine presenting, and if you're one, very feminine presenting, or you're trans, you face violence all the time. There are so many videos. You'll see somebody, a masculine presenting woman, just minding their business and get attacked out of the blue. We've had so many unsolved cases of murder and things like that. So those are the kind of things that LBQ and trans people face in my community.
Wow. Thank you so much for sharing. This is very, very heavy stuff that we're talking about here. So those that are in the chat, please make sure to take care of yourself. If you take a moment, step away, come back. But these are really important conversations. And thank you again to the panelists for sharing such important stories and information that is shaping our world. I'm going to piggyback off of what Hilda just spoke about. And this question is for Fazia. What are the solutions that can be put into place to combat challenges similar to the ones that Hilda just shared?
Some of the solutions will be sensitizing our communities on their own safety, because in regards with everything that is happening in our country and the policies that are not favoring us, we need to look out for ourselves, being that the general community has not fully accepted us. We should sensitize, be cautious on how we how we interact or even how we dress, because some of us cross dress, yeah, and we need to have limitations, because any slight misunderstanding can lead to can put our lives in danger. And we need to collect data and conduct research on the specific needs and challenges of the LBQ and trans community in regards to sexual and reproductive health and rights, healthcare services, and access to justice systems. Because we all know, without data and proper documentation, it doesn't make sense. If it's not documented, then it never happened. So collaborate, and again, with the mental health issues, collaborating with mental health professionals who have expertise in addressing the challenges of the LBQ and the trans communities, because we have trauma with the kind of violation and the backlash that we receive from the general population, and this leads to maybe depression and stress and all that. If we have mental health professionals who have expertise in addressing our issues, it will be of help. Again, violence and emergency response teams to be on the ground for timely response, because one can be violated, and by the time you get access to a violence response team or emergency response team, one could be hurt, or maybe one could end up dead. So if we have a response teams in the ground, at the ASAL areas, because most of the response that we have come from the city centers, and with this climate that we have right now, it's heavily raining in Kenya and there are floods everywhere. Transporting yourself from here to the sub-Saharan areas is very difficult. So if at all we get to sensitize and train some emergency response teams on the ground that will be in reach of the survivors immediately, when they are in violation, it will be of help. Again, community leaders, religious leaders, cultural leaders, we still live in a country where the Nyumba Kumi initiative, this Nyumba Kumi, the old men in an area who will give in to kangaroo courts to sort in some petty issues in the community. They still run our government somehow. You can go to the police station and they will ask you, have you gone to the Nyumba Kumi initiative? So if at all we put this Nyumba Kumi initiatives, the religious leaders, the community leaders at large, law enforcers and policy makers, and sensitize them on LBQ, because we are not given a good reception at any place. It's only the safe spaces of the LBQ communities that give us a good reception. Every other place we get backlash, be it the hospitals, be it schools. We have kids, yeah, they go to school and they will they'll be being told your mom is gay and all that. So if we sensitize all these people, and okay, they don't need to accept us, but they learn that we have our own rights as humans. So that will be of help. Someone will know, if I infringe her from having her own rights, I will have issues with the law, and that will be of help so much for us as LBQ and trans women living in Kenya. Thank you.
So much for sharing. Yeah, I think that's super important. I think all of us here are frontline workers, and sometimes we get so blinded by the immediate work in front of our faces. We don't really often get to do national things or international things that will actually change the course of the work and the industry that we're in for the better. So it's just beautiful to hear that there's people around the world that are actually thinking more broadly, doing studies, gathering the data safely while still protecting our folks. So yeah, thank you guys so much. This is a question for everyone, but I will be starting with the lovely Mary. Community-led organizations are doing their best to affect change in this. What more do you think needs to change to help increase access to LBQ and trans-appropriate healthcare? And how are your organizations working toward it? I kind of botched that. You want me to read it again? Or did you get it?
I have been reading it for like 5 minutes now.
Thank you.
Thank you, Tema. The things that need to change is maybe the conversations that we are having. We need to have those very difficult conversations, issues around financial resources, issues around power, issues around attitude. You know, how do we get to a point where we are able to change people's mindsets? And we're not talking about the broader community, but people within the healthcare facilities. You know, it's one thing to be able to have international support to Zimbabwe for the healthcare sector. And you have people within that sector that are providing those services who still have a very negative mindset. And to them, this is just a job. So we need, are you there? Okay.
Yep, we're still here.
So
we can hear you.
really need to start talking to issues of power, because these conversations are not going very far. You know, giving me access to a clinic as a lesbian woman living with HIV, I have managed to self-advocate and make sure that I am able to receive the care that I need. But the facilities that I am using are very, very used to me. They know who I am. They know what I stand for. They know what I will not take. So they will treat me better. So what happens to the maybe 20, 30 queer women that come behind me? You know, this cannot be an individualized positive access to care. So we have to start looking at people's mindsets. And how do we change policies if the people that change the policies have a negative mindset? Because I do believe that we all need to collect this data. But if this data is given to people whose mindset is so negative, it's just set aside. So let's do all the work that we are doing. Let's continue it. Let's continue pushing it. But let's also have those conversations from the very top. I'm not just talking in country. When that money is coming in, what sensitization are you doing to the recipients of those funds? Because if you are going to give a clinic money and say you're going to treat KVP communities, and you leave it at that, and then say to the KVP communities, you need to sensitize these facilities. That doesn't work. I cannot be the doctor and the patient. I cannot. The sensitization has to come from way at the top, because the more we try and do our work, sometimes our work, years and years of work, will amount to nothing. Advocacy is a long game. We know that. But we need to have some gains, and some of those gains to change policy, to change that will influence laws, is also changing the mindset. To the people that we have access to, we've worked very hard just to get access to people, to get access to spaces, to contribute to conversations. It's taken us a very, very long time, but that cannot amount to nothing. Yes, advocacy is a long game, but we have to have gains. We cannot keep talking about sensitizing healthcare facilities. We cannot. There should be a manual that is mandatory for healthcare facility workers to actually have to have. It must be part of some sort of curriculum. Because care of KVP communities is a national program. And I believe it started halfway. There is so much other work that should have been done first. We, as LBQ women, now have access to those facilities, all because we would not shut up. we would not sit down. We would not be made invisible. So we made noise. Now they have us running some of those committees. Right now, I am the vice chairperson of the provincial KVP forum in Zimbabwe. And a gay man is the chair. And that is because we had to push for that. Because this is our forum, it speaks to us, and we are inclusive. We are not coming in only as the KPs, we are coming in as the KVPs. So sometimes we have to have really not violent, but very radical stances that we have to take. And I do believe that those radical stances need to continue and they need to be supported. So there's so much that needs to change, but I think sometimes we have actually put the cart before the horse.
Right.
And there's still a lot of work that needs to be done. LBQ women living with HIV have little to no information, and it's very difficult for them to actually access that. I have the information because I am a queer woman living with HIV, and I've asked for it. It's a privilege to be able to say, well, I'll just Google that. Not everybody has that privilege of being able to Google something. So information needs to really flow. Women are dying. Women are dying because they are too afraid to access service, or they're too far away, or the service becomes even more mentally stressful for them. And that has to stop. I cannot die because of your attitude. It is ridiculous. So I just believe that sensitization should not be left only to the communities. That is not our job. We can help, but it is not our job. And I just believe it should be any donor or even a country position that there has to be some sort of sensitization that brings the communities to the table, and everybody can sit around there and we can speak to it. Because once the money is in, power dynamics are at play, and those silent battles start happening, and slowly the exclusion starts. There will be many posters saying, we are inclusive, all KVP people are welcome, but the reality is we are not welcome. For most people, this is just a job, and they do not bother to understand. They sit in workshops where we are doing sensitization, and they just need to leave. They want to leave. Their attitudes, I've been doing this for years, so I have seen it. People's attitudes are just like, I just need to get out. And on the other hand, we have some amazing healthcare facilities with amazing, amazing staff that we have spoken to. We have spoken to outside of workshops. We've made safe space for them to come to us to get more information. And so it's not all bad. I'm so sorry. I know I've really...
That's okay. You actually sparked another question that I have, which is actually my final question, but thank you so much for sharing. And I want you to make t-shirts for us that say, we cannot be both the doctor and the patient. We can't. So please sell that on the market. I need that t-shirt because that spoke to me personally. So thank you so much for sharing. My last question, which I will throw to Hilda first, is we know that there are often barriers such as limited funding, as Mary just spoke about, that affect an organization's ability to respond to the needs of the LGBTQ community. How would additional funding impact your response? And what would you want funders to know about this work?
First to piggyback on what Mary has shared on attitude, I think something else that we as a country, or like a country where same-sex relationships are, you know, criminalized, we have this trauma attached to us, that we have this attitude that they're not going to change, they're not going to change their mind. So it starts with us having, you know, that positive, you know, outlook, and feeling like, you know, we can have this conversation and change the mindsets, you know, of these people, and have them, you know, listen to us, and, you know, come to a certain solution, you know, that favors us as LBQ persons. And I would say additional funding will the biggest thing that I would say would help with you know, is training healthcare workers, you know, being able to organize and fund training programs for healthcare providers, and to ensure that they are equipped, you know, to offer, you know, good, respectful, and competent care to LBQ and trans patients. You know, the outreach, like Mary said, being able to have these conversations with, you know, the people that we are going to meet, because as much as, you know, we have our clinics, they cannot be, you know, they may not be accessible to every single person. And like Fawzi has been saying, especially in the, you know, sub-Saharan areas of, you know, Kenya, there may not be a clinic there, maybe an MPEG clinic, but if we have, you know, these funds that will enable us, you know, to go to those areas and, you know, sensitize these, you know, workers, like Mary said, who feel like, you know, this is just a job, I am here, you know, do this and live. That would help it in a, you know, very a big way. You know, so these agencies, you know, help us, you know, allocate adequate resources, you know, to LBQ programs for, you know, specific needs. You know, and also support, you know, existing programs, and I upscale reach through, you know, the outreach models, you know, to be able to reach queer persons. There needs to be, usually what we have noticed with especially Kenyan queer persons, you have to be something enticing, you know, to get them to feel, you know, like they are a part of, to get them to feel like, you know, they are seen, they are accepted, because there has been a lot of some organizations who just there is, you know, like things like classism, you know, still discrimination within, you know, the queer community. So with this organization being able to like hold education forums, like, you know, something like a queer event, you know, Pride is coming up next, things like that, to be able to like rally queer people and, you know, sensitize them, educate them. This was also helping a big way, because personally, before I joined MPEG, I was just, you know, not really participating, just being on the sidelines and thinking like there are people who are doing that, but there really aren't that many. So once you're in this, you know, circle of people, you realize there's something I can do personally, you know, to help with this, you know, moving forward and fighting for, you know, at the end of the day, we really want the constitution to change and all legal, you know, criminalize same-sex relationships. That is what we are moving forward to. But of course, it starts with the small things. Yes.
Thank you so much for sharing. I think Fazia has dropped off, so I will just wrap it there. Again, thank you everyone for coming. I'm going to pass it back to Alan to close us off. But this conversation has been an absolute pleasure to moderate you guys today. So thank you.
Thank you so much, Tamar. And thank you to all the panelists for this wonderful discussion. I could not have thought of a more engaging and rich discussion to observe IDAHOBIT this year. Thank you to all of you who has joined us online today to observe IDAHOBIT. We thank you for your unwavering support and continued support. This year, Stephen Lewis Foundation will be participating at the Toronto Pride. And if you would like to join us as a volunteer, visit our Partners in Pride page, which I'll put up in the chat right now. Thank you and have a wonderful day.